Hey, everybody. Welcome back to the Latched Mama podcast. It is a wonderful day in Richmond, Virginia. The leaves are changing. Weather's nice. And things are really good at Latched Mama. But exciting news. Today on the Latched Mama podcast, we are speaking with Meghan Swenck, who is a pelvic floor specialist, physical therapist specialist. Is that right? Do you want to?
Good. That's good.
Good. Okay,
good
cool.
Job.
All right. I got close enough. And we are going to talk all things pelvic floor today. Well, not all things, because we would be here a very long time. But we are going to hit on some of the top questions that we get as a brand and as a community on kind of pregnancy, postpartum, and questions that people have sent our way in terms of pelvic floor health. You're listening to the Latched Mama podcast. I'm your host, Melissa Wirt, business owner and tired mom of 5. Join us each week as we talk about pregnancy, nursing, parenting, and all things motherhood. So hi, how are you?
I'm great.
Thank you so much for being here. I know with COVID and stuff, people's schedules are a little wonky, so we appreciate you being here.
Schedule is constantly wonky, so
Totally.
This is normal.
I love it. Can you tell us a little bit about yourself and how you got into physical therapy or how you started focusing on pelvic floor health or pelvic health?
I've been a physical therapist for over 13 years and did my education at the University of Delaware.
Okay.
Which is a doctoral degree, which most of the programs are, and came back to Richmond, which is where I lived before, and started working for a private practice in town, worked there for 8 years, and then I moved to VCU Health, which is where I am now. And the specialty, it has evolved significantly since I started working. We definitely have changed our focus from mostly women to now everyone in every gender and every age.
Wow.
At least at VCU, we definitely treat everyone from about 5 to 95 and all genders.
Wow.
So there's a lot of things going on. The day is very varied.
Have you seen, like, I know you said the specialty has changed. I know I was just had baby number 5. I didn't know anything. Like, I'd never even heard of pelvic floor physical therapists back in 2012 or 13 or even 14 when I was having my first couple of babies. Is there more talk about it, more education?
I think there's more people talking about it.
Okay.
I also think that some of the changes we've done as far as bringing men into the picture and treating male pelvic floor, as well as treating the transgender patient, that has brought some conversation forward. And I think we're talking about it more. There is definitely a struggle in our field with keeping the focus on women, which was the original reason that this sort of specialty was started. So that we've got some older providers that are kind of, retiring and moving up and out into non-clinical roles. And that was how they were trained, was to treat women. And so there's a little bit of a disconnect between the older and the younger therapists right now.
Okay.
And I feel like I'm sort of in the middle because I can see both of those. But right now things are changing and there's no other specialist out there in our physical therapy field that treats men or treats the transgender client for a pelvic floor problem. So that we are doing that because we are the best, provider to do that. We didn't forget about our ladies.
Absolutely.
And that's definitely our biggest population, but it's sort of it's being a much more inclusive group at this point.
Do you know, give me a little bit of insight. We talk a lot at Latched Mama about how a woman has a baby and then suddenly kind of the baby becomes the consumer or the baby becomes the focus and the mom's kind of forgotten a little bit. And I know especially that a lot of care providers really don't interact with their patients until, they have their baby and then they don't see anybody again until, 6 weeks later. Are there certain questions that a woman should be asking her OB at that point in terms of progress or how is she supposed to be feeling? Let's just start at the very, very kind of top, hey, what's normal? What's not normal? And I hate to use that term, or, where do you normally see people coming to you? Those are probably 2 completely different questions, but
everywhere. I think the onus should be on the provider.
Absolutely.
Honestly, patients don't know what's available to them. And that's why things like this podcast are so fantastic, because people will listen and they will say, Well, no one ever talked to me about pelvic floor, and I've had 5 children.
Absolutely.
For example.
Yeah. No, I got a good blurb last pregnancy from my midwife. I have a great care provider, and I'm not saying that she never talked about it, but it didn't come up. I had a really, really bad upper respiratory infection throughout pretty much my entire pregnancy, to the point where I was wearing those Depends from, probably 20 weeks on, because every time I coughed, I was peeing. And she was like, hey, time out. Hey, if this doesn't stop when you have the baby, you need to go explore this or something.
So you could have come to see us during your pregnancy. You don't
really?
You don't need to wait. We do pelvic floor work with patients who are pregnant. If there's no reason not to, if you're not high risk and you're not having bleeding or complications, we do pelvic floor work. We have patients that have pain who need to learn about pelvic muscle stretching and relaxation, and they still want to have sex while they're pregnant, and they still are thinking of having a vaginal delivery. How is that going to go if they have muscles that aren't relaxing? So that person is at a high risk for tearing. Okay. So we work with those patients too. So we see through the whole continuum. So I think there is a little bit of a lack of knowledge of what the physical therapist is doing, what we do as far as your prenatals, your labor and delivery prep. We don't just see patients for aches and pains and stress incontinence and things like that. We see patients for just general preparation as well. And then we should really see every patient for a postpartum check. That would be great, but we're not doing that right now, and we're working on it. Okay. As a community of pelvic health PTs, we are working on it.
So, oh God, I just feel like there's like this mountain.
There's so much.
A mountain. It's like, which direction do I go? As you can see from my last question.
It's so much opportunity in one way, right?
Absolutely.
Isn't it great?
Because there's so much. There's like, I was just talking before we started this, is like, I didn't want to do a whole lot of research because I wanted to come in feeling as, unknowledgeable as I actually do, and just say, hey, what is normal? What's not normal? Let's talk a little bit about, I know for me, I'm going to go with like why I have never gone to a pelvic floor therapist. Let's start there, because after 5 vaginal births, I'm pretty sure I could use some pelvic floor therapy. My first thing, talk to me a little bit about the initial visit. Is there an internal component to it? Is it, can you talk to me a little bit about that?
Yes. Pelvic health PTs do a really great job of taking a huge subjective inventory, and not everyone has the same amount of time to spend with their patient. I have a lot of time. So we have a long list of things. We want to know about your medical history, your medications. We want to know about your births, and we ask the details. What kind of delivery? How big was the baby? Did you have any trauma? Did you have a tear? Did you have a episiotomy? How long did you push? We want to know all of that. We want to know about scars. We want to see your scars. We want to touch all of it.
Yeah.
We want to know about your history of depression or anxiety. We want to know about your fears with pregnancies. We want to know about all of those things, your family support. We want to know about your exercise, your diet, what are you drinking, all of it. There's so much that we want to talk about. Okay. So we ask all those questions, and then it helps us decide, what do we need to actually test? So, sometimes if we have, for example, a running patient who wants to get back to, running after, having a child or several children, there's a certain regimen of tests that we'll put that person through to see what is the stability of their pelvis and their limb strength, so that they can just jump off the ground appropriately and not have urine leakage because their hips are too weak to support all those structures. So, there's a couple things there, just would be almost a regular orthopedic examination, which you would see in just, any other orthopedic, facility. But then when we talk about the pelvic floor, that's when we talk about a little bit more intimate, potentially, pelvic exam. And so the pelvic exam is always explained to the patient. We use a pelvic model and we explain the muscles. We talk about the function of the muscles. And then we usually start by examining it externally. And then if the patient is comfortable and gives verbal consent or signs a consent form, then we do an internal examination. And for some patients, that's a vaginal exam. In some cases, that's a rectal exam. It depends on what they're coming in for and what their complaints are. So if you fractured your tailbone, we're probably going to be doing a rectal examination because that's how you access that area. And it's much more effective. You can't really reach it from the vaginal area. But most patients are fairly comfortable with that, especially having just had a child. Most patients are sort of ready for, yes, whatever this problem is, I want it to be, I want to know what's going on. I want to fix it. What can I do? And that often is part of it, but not always. There are lots of things we can do, especially in a patient who has a lot of pain. or has had any history of sexual trauma. Those are types of things that we're very careful about taking our time, building rapport, and giving the patient options, and always letting them stop the exam or stop the treatment at any point that they're uncomfortable. There's always things that we can do without doing internal.
That's incredible. Okay, so where do we go from here? Let's the three kind of big topics that we get the most. First is, can we talk about sex a little bit?
Absolutely.
All right, let's talk about, so everybody kind of knows 6 weeks they can have sex again. Woohoo. Let's go. And I feel like there's this misnomer that at 6 weeks, sex is supposed to be comfortable. It's supposed to be enjoyable. It's supposed to be great. And when it's not, I feel like women all of a sudden sometimes can feel like they're failing their spouse. They're not doing what they're supposed to be doing, or their partner, and all of a sudden it's like this cascade effect of, oh my gosh, what am I supposed to do? So can we talk a little bit about what happens with that pelvic floor between when it's carrying fluid and a baby and then the baby comes out? What's happening in those 6 weeks after the baby is born? And
the answer in everything is it depends.
Absolutely.
So it depends on the mode of delivery, meaning was it a C-section or was it a planned C-section? So emergency versus planned will have different outcomes there as far as pelvic floor. And then, or was it a vaginal delivery? When you get to vaginal deliveries, you're saying, was it, unmedicated? Was there any episiotomy or cutting? Was there tearing? Did the provider use a vacuum or a forceps delivery? So vacuum and forceps are called instrument deliveries, and those are associated with higher risks of tears, higher rates and risks of tears, which is going to take longer to heal. And those patients tend to have more trouble with getting back to having pain-free intercourse. So that the 6 to 8 week thing, I'm obviously seeing a population of patients that have problems. So I would say that I see a lot of people with problems getting back to intercourse. However, I think it is really unfortunate that the expectation is a 6 to 8 week. I mean, having gone through this a couple times myself, that sounds ridiculous. Just thinking of having no sleep, hardly really eating any meals. You're not even usually exercising regularly. You don't have any time to yourself. Even if you're breastfeeding, your chest doesn't even really belong to you, let alone do you want it to belong to like a partner. That just seems like a lot. And my personal experience was not a 6 to 8 week, hearts, rainbows, ponies. No,
Absolutely.
I don't think so. I asked my husband last night because I knew that we were going to be talking about things like this. And I said, what do you remember about that? And it was like, he remembered nothing about it. But I mean, we got back to normal at one point, but it was like, it didn't, maybe because I am a provider and I probably talked about don't expect this and don't expect that. And oh, this happened and, be aware. But I don't think that I'm a normal patient.
Yeah.
I think that I have more education than your average patient, but it is very challenging. And I think one of the things that I've seen happen is you see a patient and you explain to them, just like we're talking about now, that's a pretty lofty expectation. You had a tear, or, you had a large baby, or whatever, you had some event that happened, or you just had a baby and it went fine, but things got really stretched out. And you're just not ready, and you're not feeling like your tissues are all happy. And I think we need to allow patients the space to be accepting of that. And I've had several patients get misty or cry because no one told them that was okay to say, I'm not ready.
Absolutely.
I don't want to do that.
Yeah.
And no one's having a conversation with their partner or in the presence of their partner. And I think you said this in a way that, the patient often feels ashamed or embarrassed or confused about what their expectation is. And they shouldn't have the responsibility as the patient to say to their partner, I'm not ready, and have that be a negative feeling for them. Being able to say, I'm not ready, or, anything to that nature should be empowering, honestly. Absolutely. It should be saying, I know my body and my body's not ready for this. And by the way, can you take the baby for a walk so I can take a nap?
Absolutely. Yeah. But I mean, it's postpartum in general, like especially in the United States. It's just
really
not
hard.
It's not a celebrated, cherished time where women get the support that they need. So it really warms my heart that not only are they coming in and working on their pelvic floor muscles, they're coming in and it sounds like getting to have a conversation. And holy moly, do we need more people touching postpartum women in a in a special
and positive touch is so important. So if you can get to a person and say, why don't you just have a neck massage or get your feet rubbed? I mean, that is so sexy when you're postpartum. Hello. And you're probably going to have a nice little nap. But like those are the things that you're going to reconnect with your partner on. I mean, I'm not a psychologist. I'm not a therapist, but I feel like some days that's the role that I play. And that's one of the things that we do and we hear those patients, we see them for a long period of time. We create a really strong rapport and they bond with us and they share things. And so I think, and if you're going to be doing pelvic floor work, there's a pretty intimate relationship going on there with your provider. You're telling the provider things that you may not have told your partner. Yeah. And I think that's, it's nice for us as a provider. I feel really connected to my patients and I feel like they trust me. But we need to empower them to talk to their partners and bring their partners to therapy. I've done that a bunch.
That's awesome.
Yeah, it's great when they show up. Yeah.
Wouldn't it be a wonderful place where like there was this tiered approach to, postpartum childbirth, where you had, the midwife available and then you had, the post, there's so much more opportunity to really make this a special time and empower our moms after they have a baby. Yep. What are some of like the most seen problems that are interfering or impacting sexual intercourse that you see?
So scars. Okay. So perineal scars, meaning a scar from either an episiotomy or a tear. Okay. That's one of the big ones.
Is that because there's scar tissue that's formed that affects?
Yeah. All scars make scar tissue. It's just a matter of some people scar worse than others, and it depends on exactly where it's located. It also probably depends on your partner. And if you're having vaginal intercourse and we're talking about a penis and vagina, you might be talking about how big the sizes are and do they match up, because sometimes it's a bigger partner.
So then you're basically stretching that scar. Is that what's happening? Okay.
Yeah, we do. We work locally on the scar.
But what I'm saying is the pain is coming from stretching, just to try and help people who are not.
Yes. But it's almost, I mean, people will complain of a tearing sensation. It doesn't feel like, oh, that's stretching. They don't come in saying that.
Like, it just makes me like, it makes me just want to scream at the top. Like, because it's crazy to me that there's an episiotomy that sometimes happens without consent. Sometimes women don't even know that they have one or they have been given one, because sometimes care providers don't necessarily even call it what it is. Then they're told at 6 weeks, sometimes in front of their partner, okay, it's fine, go have sex. Right. And then we're putting a penis into a vagina right above a tear like that has been stitched. That's basically a full incision.
Medically, they're saying you are clear and it's healed enough for you to do that if you want to, and it doesn't hurt you. But it doesn't include all of that in the disclaimer in front of the partner usually. Absolutely. So I think there's a little tiny piece missing.
I'm sorry. I don't mean to go back. It's just it's always it's just incredible to me. I'm so happy there are people like you that also can explain to women what has happened to their body, because I don't think that's step normal. Always happens.
I would call that normal. And scars, any scar on your body anywhere, we in physical therapy work on those scars for up to 2 years pretty aggressively usually. Usually these do get better very quickly, but you have to work on it and you have to know how to work on it. And we are the people that teach you that. One of the other big things that we see as far as painful intercourse is changes to the tissue because of lower estrogen. Okay. So after you deliver, your hormone levels change and you can drop pretty significantly. And so some patients, their vaginal tissues, even if they didn't tear, but sometimes it could go either way, but just normal tissues can be really thin and feel thin and like ripping when somebody presses on them. And you can really feel this if you put your hand on somebody's tissues. You can feel at the pelvic opening, at the vaginal opening at the bottom. We call that 6 o'clock if you're thinking of the opening like a clock in a circle. Yep. So the bottom is 6 o'clock. And at that opening, if you press your finger down and then you sort of grab the tissue a little bit, it can get very thin and like almost papery in some patients and stringy. I call it stringy. So it doesn't feel bouncy like a trampoline. It feels rigid. It feels hard. And that is like almost like a transient menopausal vagina for a short amount of time. In those patients, a lot of times, nurse midwife or a physician or whoever they're working with can have them apply some estrogen cream locally. Wow. And that will make an enormous difference. It usually happens in the patients who are breastfeeding and they're not ready to be done, which that's fine. They can do whatever they want to do with breastfeeding, but that tends to be associated with breastfeeding because it changes some of the hormonal levels.
I think breastfeeding also has been known to cut down a little bit on like vaginal secretions as well. Like
you can feel a little bit more dry. So we also talk to patients about lubrications and other options for moisturizing.
Yeah. I can imagine that those two things combined, though, aren't a good,
Yeah. So there's a lot we can do with that, though. That's a pretty easy recommendation. And if most patients of childbearing age, there's no reason that it's not safe for them to have that item. So I've done that in several cases, and it's made a huge difference. Usually within 2 or 3 weeks, the patient can tell a difference, and then they'll usually stay on that for a couple months. And then when they're done breastfeeding, or as the tissues kind of bulk up, they'll wean them off of it. So it's not long term. It's usually only a couple months or so.
It's fascinating. Anything else you want to talk about on the sex topic before we move forward?
So we talked about scars, and we talked about hormone changes.
And it's okay if you're not ready. I think that that's such a major, major thing, because the amount of sex questions that we get, and they're not always like, hey, I'm ready to have sex, but it's uncomfortable. It's like, hey, we're having sex and it's uncomfortable.
Yes.
It's like this.
Yes. It's usually after they've tried.
Absolutely.
And then there's a level of confusion or disappointment or concern or, just needing more knowledge.
Is there anything having to do with orgasms at all? Is there any?
Sometimes. A lot of the patients, they haven't even attempted that yet. But a lot of women don't orgasm with vaginal intercourse anyway. The majority of women do not. So sometimes if a patient is trying to like improve the lubrication, the natural lubrication, or they're trying to improve their, activity with their partner and get more sexual touch and that kind of stuff, if they have, the idea of wanting to do that, I think that's great, because having an orgasm is going to bring all this lovely blood flow and circulation, and things get a little more like moist and excited. And usually, even in my non-postpartum patients, anyone who's having painful intercourse, if we want to get them back to having pain-free intercourse, I usually encourage trying to have an orgasm before penetration. And it can make a big difference. So it's a nice way of allowing the person to kind of get in their headspace on it, get their partner involved, focus on the female first, that partner at least first, and then, because that's the person experiencing the discomfort. If we overload the brain with all this lovely happy stuff,
absolutely,
it definitely can help kind of decrease some of the worry, because a lot of what this is fear-based. Once you have one experience with pain and intercourse, your body remembers that, and it takes so much work to undo it, and that's what we do. But any positive touch you can give in that area is helping.
It's fascinating. I feel like that's like the nugget of the conversation so far is the try to orgasm first. And it's like we had a very inappropriate work conversation the other day about, sex, is because it's a whole bunch of moms that work here, so many young kids. And we were talking about like just, sex and how often we have it, and completely inappropriate stuff. Thank goodness we don't have an HR department. But, we were talking about, and my thing is always, because it always comes up at least once a year. And, people look to me sometimes because I have the largest family apparently. And I'm just like, you just got to put your shoes on and go to the gym. It's just like you always, when you're walking out the door to go to the gym, like, you'll feel better when you come home, but you got to lace up your sneakers and you got to get out the door. So, I think that if you can start with some positive touch that gets things moving,
Yes. Also, I think after you have children, and this is this is nothing research based.
I know.
This is just me.
Totally off topic.
But I think that after you have children, you're like, okay, 6 minutes. Yeah. We can do that. Ready, go. Yes, some people need to warm up and some people need that. But like one partner can be like putting a kid to bed and the other partner can be warming up, and then you can go do what you need to do, and it only needs to take 3 minutes. And everybody's happy.
And everybody's safe and everybody's happy.
And that's great. What you're saying, I think, is true. Sometimes you just have to put, say, I'll feel better after.
Yeah, you have to turn your mom brain off, and you have to say, you know what, this is going to be great and it's good for my body. And
once you deal with the pain stuff.
Yeah,
right?
absolutely. Yeah. Anyways, okay, let's move on to this word that I hear a lot about, which is prolapse. Can you explain to me the definition of a prolapse?
A prolapse is a droopy organ.
Okay.
It not staying up where it anatomically started in your body.
Okay.
So if you think about prolapse could be of your bladder. It can be of your vagina or your vaginal vault.
Okay.
Your uterus can sort of slump down, if you will.
Okay.
Your rectum can sort of slump. All these are like slumpy organs. If you think about it like posture, it's like it loses its posture.
Okay.
And also there are other things that can happen too, but it basically means an organ that's lost some support. And anything that loses support, you're wondering, is it from pressure from above or is it from poor support from below? And that's the question that the therapist needs to answer. And so that's what we do in our examination. When we see the patient, we say, okay, what's going on with the support below the organs, which includes the connective tissues and the pelvic floor muscles and ligaments and things like that, versus what is the person doing? So for example, if we talk about running, if you're breathing in a way that pushes on the organs when you get really tired, it could be actually physically putting more pressure on the organs. So maybe that person needs to learn how to negotiate their breathing so that they can manage that while they run. And maybe they also need a little pelvic floor strengthening to support from the bottom. But the combination of those two things might be a really important winning solution. Patients who breath hold, that's, there are a lot of things that push on the pelvic area. So anything that you do that might be holding your breath. So a good topic for that is constipation.
Okay.
And that's pretty common in pregnancy also.
Yeah.
Hormonally driven. Perfect.
Yeah.
All these things we can blame on our hormones.
Absolutely.
But constipation is a big driver. And so if you're pushing and straining, not only are you potentially pushing on organs, you have hormones that kind of increase the laxity. So the organs are more bouncy, stretchy anyway. And then you can potentially have hemorrhoids if you're talking about constipation, which is not so lovely. So, I mean, I think there's other things too, of course, bouncing around, like running for a long period of time. Yep. And some patients are like they do have in their medical history, they have connective tissues that are bouncier than your average. Okay. Some people know that before pregnancy. Some people don't. They only find it out because they start having problems during pregnancy or postpartum. But that is a risk factor for prolapse.
So how does, I know from just having babies, our body produces relaxin, I guess, when we're pregnant.
Relaxin is one of the hormones, yeah.
So that is going to naturally relax some of our ligaments and tissues while we're pregnant.
Correct.
Is that eventually, once that goes away, are they like rubber bands at that point? Are they already stretched out, or will they go back to?
No, it does. You don't get it. You don't get back your bouncy stuff.
Okay.
So it's like a rubber band that kind of gets stretched out and then put in the sun.
Yeah.
Kind of.
It kind of just gets
It doesn't necessarily snap, but you can stretch and stretch and stretch. If you're, it could be any of the organs. So let's take constipation, for example. So constipation, pretty prevalent in pregnancy. So if you're constipated, there's like at the bottom of your pelvis where your bowel fills up, you start to feel pressure that you need to go to the bathroom. If you can't go because it won't come out and you're straining and pushing, so you go, okay, well, I'm leaving the bathroom. Then stool continues to fill up in the rectum. And what it essentially does is make like a pouch or a pocket, and it can stretch forward towards your vagina. So that's where the prolapse can start. So it's like instead of being like sitting in the middle, your stool kind of presses towards the front of that area, and you can continue filling up a lot. Those organs are very stretchy and they can fill and fill. And the longer it sits in there, the harder it is to get it out. The stool becomes drier, it becomes harder. And so it overstretches that vault, it's a holding space, but it overstretches like a balloon gets overstretched. So if you think of a balloon and you blow a balloon up the first time, it goes back to its original size. But every time you blow it up, it's sort of like easier to blow up and it loses some of its stretch.
Yep.
That's a great analogy for what happens. So you don't necessarily, even if you start going to the bathroom with constipation and you say, well, I'm going to soften my stool, I'm going to drink a ton of water, I'm going to use my squatty potty, I'm going to do all these things, and then use my hands to kind of push and splint and all this stuff. Those are all good techniques, but it's not going to make the prolapse go away. It's just going to help reduce the symptoms. You're still going to have a stretched area. So you always have to continue managing that unless you eventually do some pelvic floor therapy.
Can we get the balloon back?
No.
Close to the original size, maybe?
No, you cannot. You
Okay.
can. It's very difficult. So if you came to pelvic floor therapy and you said, I want to reduce this prolapse, it depends on how severe it is.
How do you know you have a prolapse?
Yeah, you feel it or you see it. So
Okay.
if you put a mirror, if you feel a bulgy thing, people will say it feels like they're sitting on a ball or a marble or something like that. And if
Okay.
you put your hand, you'll feel something kind of bulging out. The different organs do feel slightly different from the
Okay.
different walls of the vagina. So that's one area that you can feel. So if you put your hand in your vagina and you like cough or push or something like that, and you feel like your fingers being pushed out or something comes out of your body, you might have a prolapse.
Okay.
A prolapse should be confirmed by a physician doing an examination. So, you can see if you have an OBGYN, you can see a midwife, they can all diagnose that. I work a lot with urogynecologists, so they will diagnose that very often. And they have a special test they do called the POPQ. Fancy name for a test. And that's a test where you make a measurement from the vaginal opening to the length of a tissue. And then the person kind of pushes or bears down and it looks at the movement of that tissue with the pressure. And so that's the test that's out there right now. That's the standard. So we get the patients usually who have what's called a grade 1, grade 2, and sometimes a grade 3. A grade 1 and 2 is pretty mild and they don't come out of the body. But a grade 3 will be one, if I bear down or I push, you will see it come out of the body. And so once you start having things coming out, there's also a grade 4. A grade 4 is out of the body before you even strain or push. Okay. That's not physical therapy appropriate.
That's like surgery.
That's usually
something.
surgical.
Okay.
Yeah. But a grade 3, sometimes you can really lift and support and get that to feel or look more like a grade 2 and be not as symptomatic. So, I mean, it depends on the person. We don't usually see that severe of grades in our postpartum ladies, but there are a few here and there. Most of the time it's a 1 or a 2, and those are very rehab friendly. So we usually are doing significant exercise. We're managing intra-abdominal pressure with our breathing. We work a lot on the abdominal compartment and the core muscles, which is a huge topic. But the pelvic floor is part of the core. So it's all really, we treat the core. That's sort of like what we do.
You know what I love about this is like we're totally destigmatizing it. Like you are talking about it because you do it every single day and you're like, hey, it's not a big deal. You know, I see people who like it is a big deal to them, but I know for a fact that there are women sitting at home and are saying, oh my gosh, I am so scared that something is wrong down there, but I'm so scared that I'm going to go somewhere and they're going to tell me that I'm broken or that it's going to be weird or it's not going to be like, you talk about it like you do it every day because you do it every day.
Yeah. One of my favorite things that happens in the office, and I think it's really lovely and it's such a nice moment, is when a patient says, this is going to sound really weird, but, or I bet no one's ever told you this, but, and in my head, I'm saying 100 times, you know, I've seen it 100 times, whatever they're going to say, whatever thing they think is weird, I've definitely seen it before. And it always is. It's always like, well, I sometimes push with my hand and that's what makes me go to the bathroom. And I'm like, great, you're doing the exact thing that I would teach you. Let's talk about that. And they are so relieved. And I'm like, your intuition was right. And that is so amazing to see someone's face when you're like, your intuition was right.
You were doing such good work. Yeah, I love it.
Yeah. See, that's what I say to the patient. Like you said, I just say, this is normal for me. I do this all day, every day. And people do things like apologize for not shaving, which I think is hilarious. And I'm like, I'm not looking at your legs. I'm not looking at, and I don't want them to shave their lady parts. That opens up the skin to possible irritation and infection. We don't need that. That's not important. So, it's very interesting that, the expectation and the perception out there. All this seems very normal to me.
And I love it. I love the way you talk about it too, because it's so your great. Jam.
It's
and
my
I
jam.
love it.
Yeah, I love it too.
And I feel like so comfortable. I mean, I'm not going to drop my pants and be like, hey, do I have, but I think it's fantastic. Like
but you might go see someone.
I would absolutely, because it's, you just get used to just speaking with somebody who does it every day, and it's fantastic. I'm going to jump on really fast and see some of these questions that we got on Instagram today and see which ones we have talked about and which ones we haven't. Okay. So we talked about prolapses, but I believe that bladder leaks are a little different than that.
Yeah. So any kind of incontinence.
Yeah.
Do you have specific questions about incontinence?
I mean, I have one. I mean, we just got a trampoline for the first time as a family. Like, will I ever be able to jump on that trampoline without for more than a few minutes after 5 kids.
Do you want to come to some pelvic floor PT?
I might want to, because the kids want me to jump.
You have several children.
Maybe I should.
If you've never done pelvic floor rehab, you sound like an appropriate candidate.
Probably. I mean, there's been a lot of stuff going on down there.
Yeah. Yes, is the answer. You should. And that is a pretty common joke that's out there in the world about jumping on trampolines, for sure. And it's accepted that you're going to have leakage. Also acceptable in the world is the CrossFit patients who have urine leak. That's relatively acceptable in the world, but shouldn't be.
I mean, we were talking, I was working out, and they were talking about how if you do, they're the jumping jacks, but if you do jumping jacks the other way, there was like the mom jumping jacks and the regular
front to back jumping jacks.
Yeah. And I mean, it's just funny because it's like, let's modify jumping jacks, but instead it isn't like, it's like, that's just your life now. Those are your jumping jacks, as opposed to, go to physical therapy, because that's,
it can get better. Yeah, it can get better.
Okay. So there are about 3 on here that are just basically bladder leaks. Like what can we do about that?
It depends on the type of leakage. So urine leakage is called incontinence. Any type of unwanted urine leakage. So it could be you're on your way to the bathroom and you can't quite get there in time. That's an urge-related leakage. So that's urge incontinence. It could be from a sneeze or a cough or jogging. Any kind of force is called stress incontinence. So the stress means a physical stressor. That's the definition. Some people have both types. So they get labeled as a mixed urinary incontinence. So if you see MUI or mixed UI, that's mixed urinary incontinence. And that means you have some of both kinds. There are vastly different treatments for the different types of incontinence. Most of our postpartum patients are stress incontinence. The muscles are weak, they're tired, they haven't turned back on, and they're doing activities because they're a parent and they have to pick up a baby and they've got to squat down and they're doing the dishes and whatever, and they're doing all of their normal life things. They're climbing the stairs and maybe trying to do some jumping jacks, hopefully not before 8 to 12 weeks.
Yeah.
But those are things that are stressors, and that's what we usually see. It's usually partially about giving the body time to heal.
Okay.
But starting pelvic floor exercise is safe if done correctly and gently 1 to 2 weeks after delivery. We should be doing that with patients. Yep. We should be starting that. Really, it would be so great. This is a dream of mine to have some therapists working in the acute care field in the hospital, seeing you second or third day and teaching you about using your pelvic floor and how to support your pelvic muscles after you have the baby so you can go to the bathroom without pain and things like that, so that we can start the process of healing a lot sooner. Because I don't see patients until at least 6 or 8 weeks, sometimes longer.
I think my midwife gave me, after I've had a lot of babies with her, but I want to say after the first one I had with her, within 24 hours, I had a piece of paper about pelvic floor exercises.
It's amazing.
In my hand. Yeah.
Congratulations.
I know.
You're in the minority.
I mean, I guess what I'm saying though is it's not that hard. Like it's not.
It's probably provider driven. Yeah. From what your experience was that provider knew that would be helpful to you and had educated themselves or was educated in some way. I have to say, one of the things that I do find is nurse midwives in general tend to have a little bit more connectivity to the pelvic floor physical therapist and what we do, and recognize that need a little bit earlier. Not all the time. We have some fantastic physicians in this area, but that tends to be a trend. We see a lot of that at VCU as well. We see early referrals from our midwife. Lovely people.
How do you feel, this is kind of off topic, not really off topic, but how do you feel about all of the vagina trainers that are now being sold?
That's a great question.
I would love, I know I'm kind of throwing this at you.
No, you're fine.
About beforehand, but.
So you're talking about smart devices? Yeah. Like your Bluetooth pelvic floor trainer.
Yes.
Okay. So I'm not going to name any products.
Yep.
But because I don't have one.
Yep.
I don't endorse any specific ones. We usually give patients options for things. There are pluses and minuses, of course, but this is a new topic for sure.
Absolutely.
And
I do love the idea.
Yes.
Whereas you all definitely, I feel like, need to be, on the front lines, people doing it. But there's always this little twist when a startup, especially with like a Bluetooth, it's going to kind of be a tech startup. They're going to have some business knowledge. They're kind of working a little bit to destigmatize it too. I don't love the fact that they're selling really expensive things, but they're talking about it. And pelvic floor health is showing up on your Facebook feed or, which... hopefully brings people your way too, but that's my little caveat. But
I think you always, it's good to establish care with a trained therapist who can help make a recommendation. There are a ton of different items out there. There are pelvic floor stretching tools like dilators and then wands and all these special things. And some of them are shaped like an S and some of them are a stick with a little curve and some of them have vibration and some of them don't. And some of them gradually get longer and some of them gradually get wider. And you're like, oh my gosh, which one do I choose?
Yeah.
Guess what? We know what you need after we evaluate you.
Absolutely.
So CS will help you. But then there's this new device situation. So smart devices for the pelvic floor. Those are basically biofeedback. It's a feedback mechanism where it's usually a pressure sensor. So it's like a little air-filled item, and most of them are made of silicone right now, like medical grade silicone. And you insert it, usually a vaginal insertion kind of option, where it then connects to an app on your phone, which for our population now makes a ton of sense. We're doing everything on our phones now. Yep. So it's with you wherever you go. You can do your Kegels with your whatever item it is that you have. And, and it's made to be very user friendly and they're trying to make them pretty and trying to make them in a nice packaging. And so they're easy to clean and easy to use.
Yeah.
And some of them are made like a video game for your pelvic floor, which is kind of awesome if you grew up with Mario Kart.
Absolutely.
Who wouldn't want to do something like that with their pelvic floor?
Yeah.
So I think in that way, it's fantastic because there's motivational tools. So when you squeeze, when you do a correct Kegel, you squeeze and you lift your pelvic muscles, you get feedback on the screen. And so the butterfly flies up or the bar goes up or the dolphin jumps in the air or whatever it is that's on your screen moves. And I could be doing that right now, but you can't tell.
I can't tell.
Right?
Yeah, no.
So that's what's really nice about these tools. Most of the time, these are done at home in the privacy of your home. And that's the biofeedback. And that is a Bluetooth for the most part. There's a whole bunch of them out there, and most of them are waterproof or at least water resistant, and they explain how to use them. They give you all this information about lubricants. There's games, there's tracking. So there's all these things that you can learn from that. And that is actually, I think, a great option for a lot of patients. If you come and see me and you can't quite figure out how to get your muscles turned back on, how are you going to work on that when I don't see you for 3 or 4 weeks? You're going to potentially use a device. So that gives you feedback that maybe you don't have a therapist with you, but you have your device. So that can be really helpful and motivational. Because if you don't know how hard to squeeze and you're not squeezing correctly, it's like you don't want to waste your time, especially being a mother. You're like, I don't have time for this. Absolutely. So as long as if you know something's really useful to you and you feel like you're really getting a payoff, you're probably more likely to do it.
Yeah.
There are some devices out there that actually make the muscles squeeze, which are electrical devices.
Like a TENS unit or something?
Like a TENS unit, but not a TENS unit traditionally is a pain treatment.
Yep.
So it's applied in an area of discomfort. And so it surrounds that area and it sends messages to your brain and it tricks your brain. That is not exactly what we're doing here.
Okay.
There's many types of electrical devices. This is a type of device that, let's say you had an ACL surgery and your quad was super flaccid and we couldn't get it to sort of turn on and you couldn't kick your leg. You can apply electro pads. They're like pre-gelled electrodes for the skin and crank up the electrical stimulation, which we call that Russian stim, which is pretty funny because it actually makes your muscles squeeze and pretty intensely. So your leg will just kick out and that helps turn on your muscle and helps re-educate your muscle.
Okay.
And as funny as that is to see a body part move like a leg muscle, it actually can do that on your pelvic floor.
Wow.
So if you're having a really hard time turning your muscles on and you just don't feel like you're getting it, there are ways to facilitate muscle activity. So that's one of the things that you can do. So there's insertable devices that have sensors. There's also non-insertable devices. There are some newer things on the market out there, which a lot of research.
So there are things that the layperson can buy that they internally turn on. That kind of scares me a little bit.
It is. Well, see, that's where the medical provider should be involved. So there are people who should not be using electrical devices on their body.
Yeah.
If you just buy something online and start using it, there is a possibility that might not be a good idea for you for a number of reasons. And so obviously I'm a provider, so I think that working with a provider works really well. Absolutely. And I think there's a lot of little tips and tricks that can make that appropriate, more comfortable, and a lot less daunting. And also make sure you're doing the thing that you're trying to do. So if you're trying to make the muscle stronger, am I using it correctly? Am I turning it up appropriately? Is it on the right program? You may not know all that. So I feel strongly that a patient bring in that item to the physical therapy office, and then we do it together, because there's always tweaks and tips and things like that. And even patients who really are still getting a benefit out of it, there's always things that I can say, well, if you really want to do, more strengthening and it doesn't hurt you, turn it up. You're going to get more. More is better for that kind of thing. So I think there's a lot to learn there. And
it's fascinating.
Yeah, it is. It is. And I actually really love when a patient brings in an item that I've never seen, because then I get to learn too.
Learn about it.
And I can recommend it to somebody else if it's appropriate. So
it's fantastic.
So many gadgets and toys.
So much. I feel like, will you come back another day? We'll talk about it again.
What do you want to talk about?
I don't know. We'll talk about what we're going to talk about. Tell me a little bit about how local moms who are listening can find the practice at VCU.
Yeah, you can. You can literally Google my name.
Okay.
But we do have other providers at VCU, and there are other providers in Richmond, and there's a lot of lovely providers in Richmond, many of which are friends of mine. And we have a nice community of providers. And so I think what you can do, so there's two big companies, and I wrote them down so I wouldn't tell you the wrong thing exactly. So the Physical Therapy Association is a national association, and then we have websites for each specialty. So if you go on the web and you type in www.aptapelvichealth.org, there will be a Find a PT link on that website. Awesome. If you have the need for a provider in the area and you're listening to this podcast, really it could be anywhere, because it's by zip code. So you can be anywhere in the United States, and you can search by your zip code for a specialist, and it will list if they do prenatal and postpartum. It will list that. If they just do male pelvic floor, it will list that. So usually there's a list of things that person does, and then it has contact information and usually a website and things like that.
Awesome.
The other group that does specialty training in the United States is called the Herman and Wallace Group, and they do all kinds of courses and things like that, just like the National Association. And so if you want to look on their website, there is a provider directory, www.pelvicrehab.com.
Awesome.
And it'll take you right to their provider directory. And then other resources that I think are really helpful, there are some websites for patients that are patient-driven. So people who are looking for other people, I would be a little bit cautious with the Facebook groups and that kind of stuff, because sometimes that kind of gets you into a little bit of a tailspin of bad things and hearing all the negative things.
Yep.
But sometimes it's good.
Yeah.
But there is a group called voicesforpfd.org. And Voices for PFD is pelvic floor dysfunction, is the PFD. So it's about all things pelvic floor dysfunction, and it is supported by the gynecological American AUGS, AUGS. It's supported by AUGS. And so but it's patient driven. It was started by patients, and it's a really great resource. So if you're looking for downloads and things like that, you're looking for more information, it kind of encompasses anything that would be called a pelvic floor problem, from urinary bowel, pain, prolapse, any of those things. So you can learn, even if you don't have all those things, you could learn a little bit about things there.
I kind of like, just wrapping up, the major thing that I definitely want people, especially moms who have just had babies or at home right now, like, you deserve to be comfortable. Like, that's like the number one thing. Like, you deserve to either bring your newborn baby in with you, or find somebody to watch your baby, and go make sure you're comfortable. You know what I'm saying? Like, there's so many women who walk around wearing Depends because they do have some sort of incontinence or something like that, and they just think that they have to live with it. Put yourself first. You know what I'm saying? Like, it's
really hard. I think it's really difficult, because I've seen, patients say sometimes, well, I mentioned that to my doctor, but they didn't say anything. And so if they do voice a concern and nothing happens with that, or maybe it's not the top priority because there's something else medically going on, it sometimes doesn't really get addressed. And that person maybe thinks, well, maybe it's just normal. Maybe that's not something that they have any tools for me. Absolutely. And so they may not bring it up again. And I do think there's a lot of stress or struggles and being pulled in many directions. If you already have another child and you have a job that you're trying to get back to doing, and if you don't have any family support other than your partner, and your partner's working, there are a lot of things to do in the day, and it's hard to get to that part where you do you.
Absolutely.
And I've seen, and obviously tons of patients, but I see it in my friends. I see it in my family. I've seen it in myself. It's really, really tough. And the thing that I think that I hear you saying, and I think is true, is we have to ask.
Yep.
Sometimes no one's going to bring you solutions and just check in on you and gently put their hand on your shoulder and say, "Are you doing okay?" Sometimes you really do have to say, "I am not okay and I need help." And you have to somehow find that support. And hopefully by listening to this, people will at least know more about the physical support that's out there. But yeah, it's really tough. It's tough being a new parent.
Absolutely. Thank you. Thank you for loving on mamas every day.
Yeah.
Like, it sounds like you do so much more than just, the physical therapy piece. So
yeah, I try.
Thanks for, thanks for being in the trenches with us. And thanks for all the love you give everybody every day.
I plan to be there a long time.
Awesome.
Thank you so much for having me. It's been wonderful.
Being here.